so let's get going then, Doris.
Oh, and I've
Very
got a
good.
friendly reminder in the chat box before you start, Doris, to make sure that none of us are touching our face so we can role model that. And I've been reminded of that previously, so thank you for that comment.
But I am in my house with my husband, nobody else. Nobody comes, nobody goes, ever. Not even my kids, not even my grandkids. So in your house, if you are alone and you didn't bring anything inside, that's different, right? Now it's good to get used to it, I guess, but quite frankly, I'm not going outside. I'm not. Unless it's for a run and then I wash my hands 20 times. Okay, so about the webinars, basically what we want to do with you colleagues is to provide updates to the latest news. What's that? To the latest news and pressing issues. From time to time, we may bring guest speakers, but the reality is that with so many of you, you are also guest speakers because you will raise questions, you will raise issues. So not necessarily we need to bring other people. The biggest chunk of the time we want to spend on questions and answers. And then, of course, to put the call to action. And I can tell you already that the current call to action, and probably will be throughout, is the issue of one, stay at home for those that don't need to go out, and two, PPE. And it will be an issue all along. And we are fast pedaling and pushing 24/7, quite frankly, and we will not stop doing that. And we need you to do that same because that is to protect those that are facing patients from close, and that is also both to protect the patients as well as the care providers, our colleagues. So 1,000 people joined, and that's the maximum. And we will try to figure out what happened in terms of the linkage. So next week, we actually have the system fixed for this. So I'm not sure what, we don't have an explanation, but we will send to people so people know exactly what happened. Otherwise, they will be frustrated, rightfully so.
Yeah, and some people just have said, Doris, that maybe some people of the 1,000
no, imagine we have done
up.
many. Imagine, no, not 900, never. No, this is a problem with the linkage, and we need to acknowledge, own it, and fix it. And it's not nobody's fault, it happens, end of story. But likely it's a problem with the linkage because we do many of these webinars and we have done them with 400, 500. So we will figure it out. We will figure it out with the Zoom people and what we need to do different with Kyle, maybe with PG, and let's see how we fix it for next week. So let's say we will be recording and we will be posting. So let's move to the next one, please. That's the theme we already explained, and that's the hashtag of the Together We Can Do It, which is the campaign that we have going every single day. It started at RNO with us and moved forward with members and assembly and neighbors. We each went and rallied neighbors, and now it's all over, including in many other cities, including in many other provinces too. Alberta is doing it, Newfoundland is doing it, and several others. BC is doing it. So it's a great, and yesterday, by the way, several of the hospitals did inside the hospital and posted that Together We Can Do It. It was heartwarming. And let me share with you what are the issues that we are advocating. And I would like to hear the people that are joining, that have joined, if they can write in the bubble, and then one of you guys can look and tell me. Number one, if you are receiving the daily reports that we send. Do you receive the daily reports? Basically, yes, no, so we know. And I will speak a bit about what it is. What's the overall? Yes, yes, yes.
Yes, everyone's saying yes so far, Doris.
Fantastic.
And they're awesome.
And thanks.
Fantastic, fantastic. Well, you need to know, and I will share a bit about that. I don't know if I have shared with my colleagues even, of what happens for those reports. It's not a minute or two of work. First, a lot of research to see what's happening in the world. Not only research in terms of actual reading about what's happening, also research in calling our colleagues. We have, as my colleagues know, about 400 or 450 best practice spotlight organizations spread around the world. So we have many in Spain, we have in China, we have in Italy, we have in Chile, in Colombia, in many countries, about 15 countries. And I actually every day call a different set of BPSOs just to check the pulse. So yesterday I profiled Italy, that has been hit the hardest. And I profiled Loris. And then I ended up speaking after I spoke with Loris. He was so excited. It was the second time I had spoken, or the third, that he wanted his president of the federation to call me. So it really evolved into many
either
phone
in
calls.
there or I sent them this morning.
Hello, there is, can you put the phone on mute, please? So it evolved into many phone calls that really allowed me to reflect on that. And that's how I started the piece. I started by what they told me based on their experience. And what they kept saying is, tell your government to listen to you. Tell your government to listen. They need to prepare for worst case scenario. If you don't have it, that's great. But be prepared so you're not caught like us. And then they spoke about that, and then they spoke about the ICU nurses because they're super short of ICU nurses, etc. So that gave me the framework, anchored in reality, of really what it means that to write the report. And then of course I move into what we get from the government, which are the numbers, what WHO is saying in terms of the numbers, and then we do an analysis and go with this. So the 10 things that we are urging is prepare for worst case scenario. And no, I do not believe that we are prepared for a worst case scenario. I believe that for some time, the government officials have been too reassured that this will be a best case scenario. And even though RNO tried to push very, very much that that was not the case, now we find ourselves a week likely ahead of the major tsunami in hospitals. And we are still pushing for more PPE, because no, it's not best case scenario. Ideally, hopefully, I plead my heart, and I know all my colleagues and all of you do, we all want for us to be wrong and at least not be worst case scenario, at least not be worst case scenario. But we need to be prepared, and so RNO will continue to forcefully and vigorously push for preparing for worst case scenario. And we need all of you. If you are on Twitter or on Facebook, we need you to get into those social media tools, because those are tools, and really to build on the tweets of RNO that push the issue of let's prepare for worst case scenario. Second, we are pushing for PPE for nursing homes. It is the reality that people in nursing homes, especially if they are very older, that they are in very compromised health as it is. People get to nursing homes these days very, very late in life, and they get into nursing homes because that's their situation. And so it is very important to have the difficult conversations. We had a fantastic meeting with the nurse practitioners that work in LTC just before this meeting, and with the long-term care coordinators, and we spoke about how to carry on those difficult conversations. So if any of you are interested on those materials, please send a note to Olivia and we will send those materials to you. But we need to push for more PPE because those are needed right now in hospitals. Those are needed right now in home care tremendously. In nursing homes should be getting those before an outbreak, not after an outbreak. And those are the two huge pieces. And then, of course, that goes to the procurement of PPE, the extensive use of surgical masks, et cetera, et cetera. A piece that is very important to share with you is the massive expansion of ICU beds and ventilators that is necessary. So it's not that we procured a lot of more ventilators, but yes, it is that ventilators that were used by dentists, ventilators that were used by simulation labs in schools of all kinds of professionals, et cetera, et cetera. All those have been moved to the hospitals so that we can increase the capacity of ventilators. The same as, of course, you know that the elective surgeries have been almost eliminated, and so that also will free up more beds, etc. So just picture what hospitals are doing, because I have the privilege of participating in the leadership table of several of the OHTs, and I marvel. Those OHTs are working beyond belief well. I mean, if there was ever a silver lining, is that we don't need to test OHTs anymore. OHTs are working. They're working like seals because they share, they talk about protocols, they help one another. It's just heartwarming. And in that doing, there is a lot of moving pieces. So there is moving, for example, patients that are alternative level of care from in hospitals today. They are being moved to rehab centers, or they are being moved in some situations faster to nursing homes, et cetera, et cetera. And then you then start to free up more space in the event. And I would say, unfortunately, I don't think will be in the event, but more when we will have much more increased number of patients requiring ICU and requiring ventilators. The percentage in Canada today, and it has gone up, it was 2%, now it's 3%, of patients that require ICU is 3%, and the percentage of those that require intubation is 1% moving into 2%. In my report yesterday, there is a document that you should look at it, which is the Critical Care Coordination Report. It's an excellent report. And then there is a tweet of a family doctor that is tweeting, and I did put it there yesterday, that really starts to basically shape the curves, how the curve is moving. And the curve in Ontario is moving up. Time will tell if a week from now, after the holidays, basically, of people coming back and the 14th day at home, if it will start, like in BC, a little bit to slow down at least. If it doesn't slow down, we will be in for a very challenging time. So let's all hope that it does slow down, because as it will be anyways, will be challenging enough. Support for vulnerable populations. I wrote in the report yesterday that Inner City got the okay to move ahead with 4 sites for tending to people experiencing homelessness that are COVID positive, and those individuals will move to these 4 sites. The hook is that until I hear that the conditions are right, I'm not moving nurses there. And actually, Aurelio is the one that is moving nurses there from the VNRs. We absolutely are committing to tending to every vulnerable population and to everybody in general, but we cannot compromise the life of our own health professionals, as the US is already doing. And let me tell you, because that's in the newspapers, and you will hear that a nurse already died, a doctor died, This is not the US and this is not Italy, this is Canada. And we will stand and protect our health professionals. This is not when someone is swimming and drowning that you say to the other, go and drown with them. With all due respect, I said that to a reporter today. People are 100% committed to serving people with COVID, but people also have families, have friends, have loved ones, and you know their families need them too. So you don't send a soldier to the war without being well armed. We are saying to the government for one last time, and tomorrow we are putting the last statement on this. You want nurses to work, you need to get the PPE for them, and you need to get the PPE not only for the nurses, you need to get the PPE for the doctors, you need to get the PPE for the PSWs, you need to get the PPE for the midwives that go to home delivery. You need to get the PPE to people if you want people to be there for the public. You need to be there for the professionals. It's a chain. It's a chain. It's a chain. Governments have a duty, federal and provincial, to actually protect their health professionals so health professionals can go and protect and attend to the public. It's very simple for me and for RNO and my entire board and my colleagues. We are on the same page, and that's where we're moving. It is critical at this time that we be together. This is one of the goals of the webinar, that we support one another. This is where I think many of the things that I'm seeing, as difficult as they are, and my colleagues say the same, are heartwarming. In the middle of tragedy, it's heartwarming to see the caring that people are giving both to patients and to one another. The way that I see physicians and nurses and others working together is just inspiring. I wish every time, every day in good times was this way, and I hope that that will be something of the pieces that we will hold on to after this crisis is over. Next one, Susan, please. That's one of the media engagements of the many, 90 you can see in a 2 weeks, 90 media engagements. There is something very peculiar, I need to tell you. And it a bit or a lot concerns me, and a bit or a lot worries me. To me, this is the year of the nurse and the midwife. And I cannot think, and yesterday I was asked to tape a video for something big, and I said, when they asked me about the year of the nurse and all of this, I said, I cannot think of a better year for the year of the nurse. If this doesn't make our health professions shine, I don't know what else will make us shine. And I know in the front lines, RNs, NPs, RPNs, all of the health professions, RTs, everybody is shining to the best already, and I'm sure they will shine to the best after. I want government to shine for us coming through with PPE. Governments are working beautifully in words, so they are not scoring points. Can you put the mute, please, Janet? Governments are not trying to score points, which so often happens when there are tough situations. And you see it in New York. You see not in New York. You see it in the U.S. President Trump, instead of solving the issues, is scoring points on the governor of New York that is choking on what's going on. We don't see that here, and I applaud that. The premier, kudos to the prime minister. The prime minister, kudos to the premiers. Ministers working together, public health officials. So that is working beautifully, and I know it will continue. I want now to see the translation of the good talk and the important talk and the beautiful talk into good deeds and good actions to protect our health professionals. And at the end of the day, no politician, nor me, No, Susan and my colleagues that are that organize this call are going to the front lines of this fight. We are here to support you. So part of supporting you is, yes, being in front of the media to push for the issue so we get what we need, because we must get it for you. The next one, please, Susan. So here is the resource capacity. And I want to thank on this, especially Heather McConnell and Daniel Lau. Heather is the one that developed the survey with the work with other colleagues. And then Daniel is the one, well, then there is the entire IT department of RNO that very quickly develops the systems to put the surveys out in a way that people can get rapid response. And then there is Daniel and Kerry Edwards that really make it happen. They connect. Let me tell you, today there was an outbreak in a nursing home. There were 9 people that died. There is, I think, 30 staff that are in self-isolation. Lisa Levin, who is amazing, she's the CEO of Advantage Ontario, sent me a WhatsApp. This is what happened. I need urgently staff because they're sending the staff to self-isolation. I gave a shout to Kerry, took 1 second. They already are having the staff moving to them. Like it's working seamlessly, beautifully, and just amazing. There are about 100 nursing homes that we already have served with Via Nurse, because what happens is that nursing students, once they complete the first year, the second, third, and fourth year, they can work as PSW. So we are matching the nursing students with nursing homes according to location. And then we have in reserve 5,390. Well, I'm glad to see that number going down. Kudos, it means they're being used. We had 5,700, now it's less, so that's good. RNs and NPs ready to provide. That needs to be fixed, please, Susan, for the next one. They are ready to provide either virtual care or clinical care, because the great majority of them are clinicians, not only virtual. At the beginning, we were only doing virtual because of telehealth and public health, but now it's virtual and clinical. And we have already 629 or perhaps more by now, critical care nurses ready to move to emergency room, recovery room, ICU step-down units. And then we have 129 and probably more now nurse practitioners ready to go. And what you do for that, I don't know if we have the screen, but if not, we should send them the screen after. Basically, you go to the website of RNO. In the website, there is what's called the carousel. In the carousel are 4 items. The third item is the item on coronavirus or COVID-19. You click there and, oh, this is a good one for taping more, because then we can put it out. My husband, camerographer, sorry, not husband, camerographer that I allowed into my house is taping. Mr. Ricardo Grinspun, camerographer, thank you. So what you do is you go to the website, and in the website, in the carousel, you will see 4 items. The third item is the item on COVID-19. You click there, and you right away will see everything that has to do with our renewal work on COVID-19. And you will see there is a section about Via Nurse. That section has for the people that want to put their names. And then it has a section for employers. Tonight will be there. And you click and you get it there. My husband is saying that we need to take 2 minutes or a minute. Sorry, we have marching orders. Everybody with their thingies, because it's time. Whether it's Heather, Heather, we need Heather.
And you can unmute your line to do this. And there's a lot of noise outside.
Everybody.
Oh, it's time already. Okay, I'm ready to go.
Everybody the line.
Bye.
Everybody. Everybody say thank you. Everybody say thank you. Everybody say thank you to health professionals. Everybody say thank you. Everybody say thank you.
Noise in here.
Thank you too.
Thank you, thank you, thank you.
Okay. Thank you, guys. Thank you very, very much. And thank you for all the people that are working and helping keep us safe and well. So moving on, that's the two sides on the website that you public education. You will see all these pieces on the website. You can simply take them and use them, or you can take them and you can ask your organization to put their name there. We're fine with that too. Use them the best way you can, because we still need to teach people about social distance, and that's very important. And there are others about hand washing, etc., etc. Next one, Susan. Maybe you go through that, Susan. Frequently asked questions, please.
Sure. So we've grouped these questions according to a lot of people actually submitted questions in advance of the webinar. So we've grouped them into these different categories, and a lot of people are asking questions about the virus. So there's a lot out there. In the cruise ship, there was something in the news about 17 days, I think. So people want to know, how long does it last on surfaces? What do
So
we
I can
know?
answer. So here is how we will go, so we use the time good.
Sure.
You ask the question, I give the answer.
Okay.
We will go very quickly.
So, sure. So how long does it last on surfaces, type of surfaces, in the air, like aerosolized?
So in the surface, not in the air. In the surface. It lasts from 3 hours to 3 days, depending on the surface. Carton is the one that lasts the most. Hence, if they bring you groceries home, and usually they bring them in a carton, do not bring that carton home, please. What you do is you put a glove or you put a plastic and you take everything. And then, quite frankly, you wash everything. You wash everything because you don't know who packed that for you, right? So you wash everything well, you leave the carton out, and then that's it. If it's more than 3 days, there is no more virus there. You know what I mean? So if you had the tomatoes for 3 days and you didn't wash them after, or 4 days, they will be fine. I still wash everything, but that's that. Does that help?
Yeah, I think there's been a lot of rumors in the news about 17 days and some variability in that. So people were nervous.
So I don't think that there is much evidence beyond 14. But that's for self-isolation. That's not for surfaces or for things like that. Yeah.
Okay. And then people were asking about how long a person can be contagious and the incubation period versus the communicability period.
Well, first of all of that is in the website of Health Canada. So I would suggest that those very specific clinical issues, we can pull them from Health Canada, Susan, and send them, rather than me trying to pick what Health Canada says.
Sure. Yeah. That sounds great. Yeah. Okay. I think a lot of people want to know more about PPE and masks. So I think they would like your advice. And someone's got their, if you could mute your line, please. I hear some background noise. So what if they don't have enough masks? Where RNAO is advocating strongly for it, but what if they don't have the masks? Are homemade masks okay? What are they going to do if their employer isn't providing masks when they feel like they need them? And rationing of masks. So what do you want to say about that?
So what's happening now is that everybody's getting in a hospital 2 masks a day. When you come in, you get 2 masks a day, and surgical mask. And then if that mask gets dirty, they change that mask for you. We're pushing that be the case not only in hospitals, but the same should be the case in home care. The same should be the case in nursing homes. And as I said before, nursing homes, not after an outbreak, but always. And that should be the case if people work in correctional facilities or anywhere, quite frankly. So that's our position. You will see very soon that some home care agencies will be moving there. they're so frustrated with the situation of purchasing that they're going ahead and purchasing themselves what they need. So that I think will be a wake-up call for government to move faster. We do not buy at RNO on the issue that we cannot get them, that there is a shortage, because there are many importers that are bringing them. I have brought to the attention to government some. So we just think the government needs to fast track. First of all, they need to change the framework and the parameter of this will be best case scenario. As I said before, if one thing Italy is telling us and Spain is telling us, and now look at the news in the US, is that we better be prepared for worst case scenario. Hopefully we will never get there, but we need to be prepared, okay? We will tackle it in another webinar if we get to if we don't have anything, because we will see what position RNO takes them there. Okay. So far now, your job, all of you in the call, is to get into Twitter. We are tweeting a lot. RNO is tweeting a lot. I'm tweeting a lot on the issue of PPE and on the issue of we need that now and we need you all to retweet. They need to feel the pressure that you are in the front lines and you absolutely need that. And some nurses have been very courageous. They have gone even into CBC National. So if any of you is willing to talk when you have a big issue, connect with us, depending on what's the issue. We will do homework, we always do. For example, yesterday or the day before, I don't remember, a reporter called me about a memo in a specific institution. And when the reporter called me for my reaction, I couldn't believe it was true. So I said, sorry, I can't comment unless you send me the memo. And sure enough, they sent me the memo, and the memo said, use this N95 until it's grossly soaked. And I basically took that, sent that to the ministry, said remove that memo and replace that memo for what it is that we are asking, which is if your N95 or your surgical mask is very dirty, you call the person that is in charge. There is a person in every one of these hospitals now, and they will replace your mask, right? So we cannot leave all the masks out because they are disappearing, and they're not disappearing because nurses or doctors steal them. They're disappearing because everybody's afraid, right? And people are afraid tomorrow there will not be enough. So people, stock a few, or they're using a lot because things are complex. Things are complex, right? That's our position. You need to get the 2 masks a day wherever you are working. And in my view, you should push for that because you should not put your patients at risk, first of all. You come from the street. You don't come from, so you're putting your patients on risk, you're putting yourself at risk, and you're putting your colleagues at risk. That's our position.
Doris, there are a couple of questions on that topic about masks. Can I ask them now, since you're on the topic? Okay, so people are still curious about the homemade masks and whether or not they're appropriate.
So the homemade mask started with an initiative that Jeff Powey, the director of infection control at Michael Garron Hospital, started. He in fact called me before this was public, and I was touched to no end. And in fact, I profiled him in a tweet and also in one of our reports that we did, because he actually gathered and first of all, they developed a protocol for it, and then they sent a mass challenge to anybody that has a sewing machine at home and that is stuck at home, and said, you're stuck anyways. You have a sewing machine. Would you be willing to make a mask? And here is the protocol. And by the way, that is on the website of the Michael Garron Hospital Foundation. And it's not to get the donations. It's simply because that's where it is. And people are doing gazillions of beautiful masks, but those masks are not and never were intended for professionals. Those masks were intended, and look how brilliant this gentleman, this Jeff is. They are intended for people in the community. He wants that in this community of East York, every person that is 65 or older, he wants them to wear a mask when they go in the street, even if it is to put the trash out. And that's what the mask is. So look, in one hand is protecting, you know, seniors. In another hand is occupying people that are at home, you know, stuck. And it's building a sense of community. We talk about collective identity in our BPG program, and it's collective identity in live, and it's amazing. It's really quite inspiring, and all the time they have more and more and more and more, and they are going to distribute that to vulnerable populations. There is a lot of homeless people that live in homelessness here. There is a lot of people that have issues of substance use. So it's not only older persons, and they're going to give them to vulnerable populations. So that's the intent of those masks.
That's really helpful, Doris. Another question about that is, like, if you're going somewhere like a grocery store where it's hard to keep your distance, do you recommend a mask? A lot of people are wondering about just going out, average person going out in the community.
Yeah. I can't think of, I haven't been in the supermarket because I'm not going. I really am not going. I'm one of those role models of stay home. We order, it takes 10 days, 15 days, but that's what we are doing here. But I cannot picture that they are packed, the supermarkets, are they? Really?
In some cases, yes.
Wow. Then
Doris, many supermarkets are now restricting the number of people, and there then are lineups outside. However, they've marked the sidewalk in many cases, but still some people feel that it's close. So I think the mask is probably a good idea.
Then I would say if you have a mask, put the mask.
Yeah.
But
stop. Make sure they're not the ones that are depriving healthcare workers.
No, the cloth one.
Yeah,
I mean,
these ones we're talking about,
yeah,
right.
These ones, yeah. And then Heather, I remember, had a great idea about the handles. I remember. She said about plastic bag to take the handles of the cart, right? Because remember, that cart is touched by everybody else. So don't do this that I do all the time when you are touching the supermarket cart, right? So those are things that we need to pay attention, because usually we don't. I was so touched and also impressed because she's only 2.5-year-old, this little one that I keep saying this is her toy. And not anymore. That's not a toy anymore because she's older. They came in the bike. The kids with the parents came in the bike. They kind of called us before to come out. We were inside, like total inside. And she didn't even, she's one of those, like a little puppy that will say, I want to go, and she runs. She was so sober and looking, and she didn't ask me to come. She didn't say, I want, she so understood what was going on. I mean, you wonder sometimes what will be the impact on kids, how quick they will respond. But hey, I lived in Israel, don't forget, 3 wars. So I see that people get back to life like if nothing happened before. They just appreciate life a bit more maybe, right? But you wonder, right? Because 2 weeks at home, parents teaching them, and you know what I mean? And many of my colleagues, I can think of the colleagues on the line now that you are going to work. I heard one of my colleagues explaining that how she was explaining to the kid how she protects herself, because the kids hear about this. And they're afraid that something will happen to mommy and daddy when they go to the hospital. So it was so touching to see how the parent explained how they are protected. Yeah.
Yeah, I have one comment
Yes.
about that. The WHO, the World Health Organization, has some excellent tips on how to be a parent during COVID-19. So
Send that to us.
Yeah.
Or you know what? Send it to on my report. That's
it's great. And before we move along from masks, Doris, there is a question about N95s I'd like to ask. It's Erica asked, please elaborate on airborne transmission, because Public Health Ontario states only airborne is when aerosolized, But today, the Ontario government aligned with ONA recommendations that the N95s be available for nurses if there's a clinical indication for COVID-19. So some questions about that.
Here it is. So this is the negotiation between ONA and the government. And yes, this is what they came out. I will never do anything to undermine my colleagues at ONA. I need to tell you that. That's number one. But I do think we need to be very cautious with that, because the more we use N95, the less we will have when we really need them. So evidence-wise, the evidence is what WHO is saying, and it's very clear, and I'm not going to go over that, because there is a full protocol that people can get from both the Health Canada website. It was in my reports. I put it several times, and now there is this that basically says the nurse can make his or her own judgment on that. Yes.
Thank you so much for that. And maybe we'll move along to some of the other topics, Doris.
Yes.
So practice safety. So still some inconsistency that people are finding in their workplaces about returning to work after travel, or how long after.
So that is clear cut, period, end of story. And first of all, let me start at the end. No one should be traveling now. In my view, and we have written that in the reports, I have put that in the reports, unless it's an emergency that you have an ill family member or something very major. Really, guys, people should not be traveling if they're health professionals. We need you here. We need you here, period, end of story. It's as simple as that. So the issue of traveling is a bit not there anymore because the time passed, right? But it's still the same. It's 14 days after you travel, you need to be in self-isolation. And that's clear cut.
Yes, so Doris, in addition to that, people are wanting clarification from their employees about the symptom-free, like if it's 48 hours of being symptom-free and when they can return. There's
14 days, 14 days.
Okay. Oops, sorry. Shall I continue with the list? Yeah. Use of ID badges as a possible vector or fomite for the virus.
Wow.
Do you have any comments on that? That was brought up by someone, and I think a lot of people probably haven't.
That is brilliant, and I never thought about that. That is brilliant. In my view, put it on the pocket. Sorry, you know what I mean? Because you go from room to room to room to room. I don't know. Now you go to room yourself too. You know, if it's a patient that is not COVID positive, if it's a patient that is COVID positive, you don't go without all the, you know, and you're attending to them. Yeah, I can ask. I never thought about that one. Yeah, but it would be like they tell you, clean the phone. First of all, stop giving the phone from one to another. Mm-hmm. Period. Inside the house with the people you live, yes, you live with the same people, right? But aside of that, no giving the phones. If you are at work, don't say, "Oh, look, just look what I received. Read it." You know, we usually do. We say, "Oh, look at the picture. Look at the this. Look at the that." Right? Look at the BPG. Look at how you do the. No more. And this can be clean. You clean them with the same stuff that you clean your hands.
Thank you for that. And actually, Lynn just said that the WHO has some guidelines for ID badges.
What is it?
I'm not sure, Lynn, if you have any more information you want to put in the chat box, we can read that out.
That would be great.
About the ID badges. It's really helpful to hear from the community online.
That's great.
So in terms, while we wait for Lynn, testing. People are wondering about healthcare, boosting up the testing for healthcare providers. Should the criteria be expanded? And
So number one,
right.
healthcare providers are priority number one. So if you, except that they don't test everybody, if you have no symptoms, right, and you were next to a person that tested COVID-19 positive, they send you to self-isolation, that's all. Because we don't have enough testing, right? We don't have enough testing because it's complicated, the testing. It's not only the swab, it's all the materials at the lab that we and everybody else in the world is short. So on that, don't expect that if you were next to a patient that is COVID-19 positive, that you will be tested. They will basically send you home to be in self-isolation. If you are a very essential healthcare provider, meaning one of you is the only NP in the unit, let's say, or whatever, right? The only RN that has whatever specialty, then they may test, but otherwise they're not testing everybody, but yes, they're sending for isolation and they should.
Okay, thank you. Staffing, did you want to say anything more about plans to deploy nurses? For example, nurses who work in ORs where they're non-essential operating rooms, or nurses from ACLS, they could be redeployed for other purposes.
So it came part and parcel with the issue of stopping elective surgeries. That's one piece. And the other with the issue of freeing up space for more ICU beds. So we moved ALC patients, or in some places, out. We moved other type of patients. The hospitals have hotels already assigned or rented or whatever is that they did with them. In case that there is a huge surge in hospitalizations, they're ready for that, and they have been working day and night in an amazing way. On the issue, then you are left with staffing, right? So the staff that work with ALC patients, if that's the only patient population they saw, will move with those patients to the new unit, because the new unit doesn't have, a surge capacity either. They may have the space, but not the staffing. But on those that we complete, that we're not doing elective surgery, so you are OR nurses, you are recovery room nurses. So you will scale down your recovery room, and many of them are already being retrained in a very, very fast way. What usually is a course like this is given like this to be ready for either step down or ICU and ventilated patients in ICU, which still is two different levels of expertise. So that's happening already. Yeah. Still, I think that we will be short-staffed, and that's why I am saying to my colleagues, the chief nurses, that they need to now build surge capacity. So don't think that you are okay. Just bring a few more nurses. First of all, it will allow people to just relax and not be so stressed, and be more prepared for tackling this. Second, if someone becomes sick, or someone is a single parent and the kid is sick all of a sudden, and the babysitter or whatever arrangement cannot come, things happen in life. They don't stop to happen because we have COVID-19, right? So that then they have the extra hands already, and they're not scrambling last minute. So we are speaking with them, and I put that in my report last night. Approach us now, and many are approaching us, and when we are done, because we have what we have, right? But we will send, and that reminds me, Heather, that we need to send, remind me to tell Daniel tomorrow to everybody again, everybody in the system. Yeah.
Okay, thank you, Doris. A couple of more questions here, and then I'll maybe jump to the chat box. But end of life. So one person was asking, staff are able to gown, glove, and mask to be with a patient. Couldn't a family member be able to be at the bedside of a person who is dying, so that they can offer, be there for support and compassion? And yeah, any thoughts on that?
Yeah, well, the policy has been, and so it's not about my thoughts, it's about the policy, has been that no, that staff accompany people at the end of life. I am not sure that there are exceptions for that. I could check and bring it back to the next meeting, or we can have a Q&A, Susan, in between that we can build on it. In nursing homes, it's clear why, although now they're letting volunteers. They did a new order yesterday from the ministry, and volunteers can come in. So then I really don't understand why families not. So we should check with that, Heather. Remind me, now that the order is for volunteers, probably we should. But volunteers get training, families not necessarily. I don't know. I will talk with Lisa today, and I will ask her her thoughts. Lisa from Advantage Ontario, and tomorrow in the morning I will ask Dr. Williams about that. That's a good question. But don't forget virtual, and don't forget only, so palliative care patients is one aspect that is critical. The other that is critical is people at home, whether they are older or not older, alone, right? That they're self-quarantining and they live alone. So I think we need to really encourage way more what we are doing. What we are doing. It's kind of, it's the new way of being, right, for this period of time. But to encourage more the use of technology. Being alone doesn't mean being alone. You can be connected through WhatsApp, you can be connected through Skype, you can be connected through FaceTime, you can be connected, in so many ways that, the other day I just did, and in fact I did it even in the television. They were asking me for tips in the Chinese television, and I told them, well, let me show you what I just did to my grandkids yesterday. I said, and as I am doing it, I did exactly this. I took my sock and I started to do puppets, right? And I did puppets yesterday and the other day with the kids with different socks colors, and they were laughing their heads off as if I had done the most interesting thing. Well, with seniors, with older people, or we can read poems, we can read stories, whatever we know that our mother or father or spouse or son or daughter or grandkid or friend that they like, let's do a bit of that, right? I shared with my colleagues that yesterday, my niece passed away in Israel from cancer. Later that 44-year-old with 3 kids and her husband. Well, today it was only probably 7 minutes in the morning, and we had a chat with them, and they showed me, one of them showed me his eye because it was red, because I think he has pink eye, and so I gave him tips of what to do. And there are so many ways, thanks to technology, that we can be together today, even if we are not physically together. And we should encourage that, because this is not going to be a short haul. This is not going to be a short haul.
Yeah. Doris, there's one last question on here. And I think, it's about inappropriate viral videos. And do you have any advice for people about all of these crazy things that we're seeing out there? People licking their hands and, like those kinds of things. Any thoughts on that?
My first thing is to not tweet, to not like, to nothing. The moment you answer and you start to tell them this is inappropriate, you already are giving them legs. Do not answer, just erase it, move on. Now, if it happens, like it happens to me with people that I really care, that someone sends you something at the beginning because they don't know any better, and they're just sending emails from everywhere to see if it's true. then of course answer them, this is, absolutely not true, and this is the case, and do not answer, and blah, blah, blah. But do nothing with it. If you answer, that's exactly what they want.
Thank you. I think maybe there are like 5 more questions that I have that have come through the chat box. And Heather, tell me if I've missed any. But can we go through those before we close, Doris? And there are a few other slides that we have. So just arriving at case numbers, someone was asking about arriving at case numbers. How do we do that if not everyone's being tested? So.
Brilliant question. Brilliant question. So more than that. So case numbers is from those that were tested. Hence why RNO has been saying for some time that we have community spread. Because we knew that there are some already community spreads, which means community spreads mean they couldn't link it back to a travel or to another person that had traveled, right? They just couldn't. That's when you started to hear community spread. And the percentage that we test is relatively very small. So case numbers are within those that we test. And moreover, the death rate numbers are related only to those that we test. So this is the situation with nursing homes that I was talking with the MPs before. Likely we will see a surge of people, residents of nursing homes dying. Supposedly, when a senior in a nursing home or a person a resident in a nursing home has any symptoms, they are supposed to test. I don't know if it's always happening. If they are tested, it's counted. So if someone dies, whether it's at home or in the hospital or in wherever, in the grocery store, and they had been tested, then yes, the death is linked, unless it was a heart attack. I mean, that can be discussed, but it's linked to COVID-19. If the person had not been tested, then it's not linked to COVID-19. So the question will be at the end of this nightmare, when someone will ask how many people die in nursing homes for the period of January, tarara, first case in Ontario, to, let's say, likely, I don't know, end of May, mid-June, I don't know, how many people die in nursing homes, right? And then we will say how many residents of nursing home die that were COVID plus COVID-19. And we will know because those were measured. And then the remaining, one needs to say, is this remaining group of residents that die in nursing homes during this period, how does this match to last year, the same period? And then we will know really how many more, in my view, die out of COVID-19 that simply were not tested for whatever reason. So at the end of the day, to me, it's not only about numbers, and to my colleagues at RNO, and I know to all of you, but it is really, at the end of the day, to honor the lives lost. People will die also of other things during this period, either because the system was overwhelmed, or because we canceled the surgery for whatever, or, I mean, they're trying very judiciously not to cancel surgeries that are life-threatening. But, it's a pandemic, and it's a very difficult time. And at the end of the day, we need to be able to look back and to say we did all we could as a country, as a province, as a people, both the community, the professionals, the governments, the media, to save lives. And let's honor those that we lost, because we will lose people, and we already have lost people. So.
Thank you for that, Doris. I'm just looking at the time, and it's 8:05. So I'm wondering, some of these questions perhaps we can answer after the fact and move on to.
How many you have? How many you have?
Well, there are a couple more have come in, but.
So I can answer very quickly and not long.
Okay, sure.
How about that for a deal?
Okay. So self-testing kits for healthcare workers, UK has been deploying them. Do we know anything about that?
So my understanding is that we were looking into that. I'm going to inquire tomorrow. How is it moving? Yeah.
Okay.
And
Great.
those will be delivered to people's homes. Yeah.
Okay. Non-disposable respirators for staff. Let me see. Heather, do you have any more information on that one? I just jotted that down. Oh, you're on mute, Heather.
No, just an example, non-disposable respirators that they have at Henry Ford. That was what the question was.
Yeah, any likelihood they'll be here?
Non-disposable respirators.
Yeah, I never heard of
I
that.
don't know of any respirator that is disposable. Like, you're not
No.
talking ventilators, sorry, respirators. Okay, sorry, I was thinking ventilators and couldn't understand. Yeah, I have seen so many things from the US, from trash bags in the body to now non-disposable respirators. Let me check on that. Keep it, Susan, and we can check on that.
Sure. Okay. Kind of a request, I think, that RNAO puts out a statement about homemade masks for healthy individuals.
That's an idea. I mean, if we do it, would be to support Michael Guerin, because it was their idea. It's like the Together We Can Do It is our idea that now everybody's using.
Right.
That's their idea. What we can do is to promote it. Absolutely, yes. And it was in my report. We can put it in our website. If you can talk with Madison tomorrow, Susan, and put it in our website, I think it's a great idea.
Okay.
Because they have a very good explanation, both about the protocol, how to do them, like the model, and they also explain why and for whom. Like, I wouldn't want for people to think because we are saying it is instead of, procuring more PPE.
Yeah.
No, and that's the thing that we have to be really clear on. I do know that physicians, the UHN physician that's on CTV was talking about it as well, but saying it's for the public who would feel more comfortable with a mask.
Well, imagine I got a frantic email from 2 colleagues as a result of, before it was even in my report. What are they doing in whichever hospital and because you can understand the confusion. Like we are talking all the time, we don't have enough PPEs, and all of a sudden comes this cloth PPE. People, of course, rightfully so, think is for professionals. So what we can do, but let's think about how to do that. I think it's a great idea for community. And we have lots of nurses also that are at home with a sewing machine that have retired or something that can do, that not always they go to do they can do the masks then.
Great, thank you. I've seen that there actually been a flood of other questions coming in, but before, and Heather's monitoring the chat box as well. So we, the more we answer, the more questions arise.
I don't mind if people have time, and those that want to leave can leave.
So a question about a community of practice, or maybe a suggestion about a community of practice. Is there a mechanism where nurses or nurse leaders can share their experience in models of care?
Okay, that's Heather's job. Heather will set it up with her group.
Yep, I already made a note. Thanks, Doris.
I think it's a great idea.
It is.
And maybe you want to do 2 different ones, one for, I don't know, let's ask the person that asked if they think it should be one for managers and one for staff. I don't know, or maybe all together. Let's do all together. Let's do all together.
Yeah, she asked models of care or practice changes, and I think that's great because if there's
So
any
let me
silver
tell you.
lining,
So
it
let
may
me
be
tell you,
innovation.
the best model of care that I have seen in terms of, I was impressed beyond belief, and let's ask Vanessa Burkowski and Natalie if they can share the slides because I saw them. They developed a model of care delivery that maintains continuity of care despite all these transitions and all this retraining of people. So I commit
Fantastic.
to ask her if I can share the slides and we can post them.
Wonderful.
Yes. Susan, you are on mute.
Thank you. I think some of these are actually responses to questions. Heather, is there anything that stands out
But
to you?
maybe read the responses so we know what people said.
But Susan, there was the question about testing post-mortem
Yes.
for COVID.
I doubt that anybody will test postmortem for COVID.
Yeah.
There was the situation, here in Ontario, the first outbreak in a nursing home. It was a gentleman that had been in touch with someone that was COVID positive, and he didn't know at the beginning. And by the time he got to the hospital and he passed away, then they discovered that, and he had already contaminated other people. And of course, there were other people in that home, was, I believe, the first outbreak. But I don't think at all imagine that they tested him, that they did postmortem.
Mhm.
Okay. And what about children?
Imagine it will be very, very, very time consuming, doctor, right?
I know.
Yeah.
Yeah, there's a question about testing children, increasing the amount of testing on children. Any thoughts on that? Should we
Well,
advocate for children
well,
to be tested?
touch wood, touch wood, touch wood, touch wood. We yet don't have cases of children, and in the world there have not been many. And it's not a pleasant procedure, guys. I can attest to it because they did it to me, because I had that cough and I've been with everybody. Negative it resulted, but it was not pleasant. Like, it's not terrible. They just stick a thing into your nose all the way to heaven. It's not pleasant, it's not, but that's why people use the shield, right? Because you can inadvertently,
Sure.
right, cough, but yeah. So I have not heard, nor do I know if it's necessary, simply because of the evidence that there is there. There is a 40% of cases we know that is age 20 to 40. And that is for you guys that have either children or brothers or friends or siblings that think that they're invincible. And because Dr. Williams said 5 people can be together, they think that 5 people can be together, cheek, cheek, cheek with the beer. You know, 5 people together with social distancing, man. It didn't mean 5 people together to, you know, yeah.
Okay, thank you for that. Question about once a client is contacted and recovered, contacted the virus and recovered, are they immune to the virus? I don't think we know that yet.
We don't know. We don't know yet.
Are there any cases of second sicknesses? I don't think we're sure of that either.
Yeah.
But we could check for it. We could check for
Sure.
the person that asked. I am not aware of that, because probably you are immune for a period of time. Probably not for a long time, but for a period, and I'm not sure what that period is.
And I don't think they know.
And there's just a comment that in First Nations housing, there's overcrowded families living in one household, so that's a great concern.
Touch wood, like with the kids, and maybe it's because they how much they deserve to be in a better shape than the rest, for once at least. We haven't had major issues, and we are ready for it, though. Hopefully never will happen. And it can be because they're more isolated and more, you know, so that may be playing in the favor of Indigenous people. But if it will be there, it will be a disaster, simply because of the crowdiness and the social conditions. Same as what's going on with shelters. Why are we rushing to open these places for people that are COVID positive in shelters, and because it's a disaster, because they're just, right? So by the way, on the issue of First Nations, we have nurses in the survey that Heather developed. There is a special section for Indigenous people. And so we also have people ready to go there too.
Great, thank you, Doris. Someone is asking about liability issues returning to work after many years. And I'm just thinking that we can maybe refer people to Mara for issues, or maybe even have a webinar on that topic.
But Mara will not know the issue of Brad. So don't please send them to Mara. Everybody that is a RNO has PLP and is covered. I would suggest that you also get a LAP if you need, but LAP is for employment issues. I mean, if you haven't been for a long time at work, first of all, I thought the college is doing something on this. You look in the website on small preparedness, and also the workplace will give you the preparedness. At the end of the day, they will not put you with the most, complex patient, but you will be, even if it is with patients less complex, and someone else will be able to do that.
And I think the person just has to be really upfront with the employment setting, so they know exactly what your limitations are. And then, as Doris said, requesting some type of clear orientation and education.
And just a reminder that we are having a webinar next week on the 7th of April about the LAP webinar is focusing on legal issues in nursing practice related to COVID-19. And you're welcome to register for that 5:30 to 7:30 next Tuesday.
So I suggest, Heather, that we send alongside with the next Monday. Susan, maybe you can work with Olivia. Olivia is on the line, right? To send both, to send the Monday one and the Tuesday, both of them. Yeah. And post them in the registration, one next to the other.
Okay, Heather, can you help me identify if there are any outstanding questions there, please?
I don't think there are any more.
Just some questions. We had a couple of just clarifying what non-disposable respirators were, so thank you for that. And
can you read it?
Just to say that non-disposable respirators are the ones used by welders. And they have disposable filters that get changed, and they look like gas masks, but they change the filters periodically. So they're just wondering if that had been thought of.
Well, I have seen people with that, but you're right, in the US.
Yeah, I've seen that in the US too.
Yeah, I don't know. Yeah, I don't know if, I'm assuming they're good, but I don't know enough, but we can ask, certainly, I can ask Dr. Williams tomorrow, yeah. Send me the question, Heather, so I don't forget.
I got them all noted here.
Thank you.
And I think just one question, and Heather might actually have the answer to this, about quality control for masks donated to hospitals. That some masks that have come from other places have been defective. Any thoughts on that?
Yeah, so right now we are taking an inventory of masks and other PPE that are available through sources such as schools of nursing, dental offices, etc. At this point, these are all products that have been approved for use in Canada, and we are looking to distribute them to long-term care homes and other sectors in need. So I really can't comment on other products that are being brought in for other purposes, but the ones that are currently approved for use in Canada that are in inventory in certain sectors or places, we are redeploying those right now. So I'm not sure that really answers the question, but that's all I can say right now.
So I got 3 WhatsApps of people trying to get in. Susan, we need to send an email ASAP today to everybody saying we're very sorry and we will test what happened. But yes, the event did go on because they think it was canceled. So the event did go on and it will be archived, and we will send it.
Will, and we're very sorry. So if your colleagues have not been able to, so we're looking into it and trying to figure out why. So
yeah. So augmenting Heather's answer. Number one, the ones that we are bringing, we put them in a plastic bag for 4 days, and then they're COVID-free at least. We send them if it's closed boxes. Okay. if there are open boxes or another type of things, if worse comes to worse, number one, if N95 are defective, they can be used for fit testing, okay? So they are good, but there needs to be very clear, use this for fit testing. If there are other type of masks that they're not good, they can be used as surgical masks. It's better than nothing at the end of the day. So don't dispose of any of it, because we can always ask. I can go back and ask how can they be used. But we did actually, in the statement that we did with the OMA, we spoke, the province was going to get rid of a large quantity of masks that had expired last year. And we said, absolutely not, absolutely not. And so they're being used for fit testing, they're being used as surgical masks, right? You wouldn't use it for doing a tracheostomy procedure, but for other things, yes.
Okay, Doris, I've moved the slide on because I think we've answered the question successfully. So on to a different note.
Beautiful. So this is really a time that it's good for you to build a community with your neighbors. You know, if you know that there is someone that lives alone, if you know that someone that needs something, this is the time. This is the time to build community with your coworkers in different ways. People that are in isolation, people that are going to work and being concerned when they leave to work, how that will impact them and their family. I have received several questions of people, can I stay in a hotel? Can hotels be fixed for staff because they don't want to go back to home necessarily? So this is a time to be together, to not be afraid to ask questions, to not think that your question is less intelligent or less important or more important than the other. This is a time that all of us need to be pitching in, the public by staying at home. That includes your families if they don't need to go to work, so they understand. Health professionals to continue to be experts and courageous and compassionate. Don't forget, please, the compassion in the midst of these difficult times that you will encounter. Compassion for colleagues, compassion for some colleagues that may lose their patient because they are stressed out, and compassion for patients that don't have their families next to them. And I will ask about the issue of palliative care patients, whether in the hospital or at home or in a nursing home, of can families come in. And this is the time to be compassionate to governments. I mean, that doesn't mean that we don't push, right? Yes, we continue to push for PPEs because that's what we need to do. But that doesn't mean that we don't say thank you when in many aspects they're doing and pulling together like never before. And we are all pulling together really quite beautiful. I mean, you watch the news in the US and you watch the news here, and truly it's a different world. And that's not to diminish the importance of people in New York, because, hey, my son used to live there with his family and it's a beautiful community. I'm glad he's here now. But you know, it's a beautiful community of people, but the politics in the US, unfortunately, are very different than the politics here. And my gosh, this is Canada, and together we can do it, and guys, together we will do it. It's not a pitch hole, it's a tunnel. It's a tunnel, and it will be light at the end of the tunnel. Absolutely it will.
Doris, I just wonder if we could have one more question. It's from Claudia, and she just said, oh, my question wasn't answered. Is there a way to educate the public who are in self-quarantine with symptoms of COVID, how to treat their symptoms rather than visiting the ER when they are very ill?
So first of all, no patient goes to the ER without calling before. That doesn't happen anymore, okay? Because if they go alone, they will, unless they are really sick, and then they need to take them. Otherwise, they will send them back home right away. And no ambulance will take them unless they're really sick. And if they're really sick, they need to go, because we don't want to miss the boat either, right? There is a danger between saying stay at home, stay at home, stay at home, which is true, and be careful not to say stay at home when a person is short of breath, etc., and then we may find a tragedy with them at home. But there is the self-assessment tool, and I put it in my report, I believe again last night, the night before for sure, and the night before for sure, is outstanding. And the reason why we need to become champions of that self-assessment tool is because also will provide us data, because they're tracking that data of people doing the self-assessment tool. So then really they can track where things are moving, how are things moving, and that's very good for really looking at how we continue to tackle this beast. So thank you. Is that Claudette Bennett?
It's Claudia. I'm not sure, but
Claudia.
Claudia. I understood Claudette. Okay.
No.
Yeah.
Thank you, Claudia.
Yeah. So we spoke about this cheer, the nightly cheer, 7:30, to get your friends, your neighbors involved. Keep your distance, but please get active, make noise. People are playing music, they're singing, they're doing all kinds of creative things.
And you know, guys, what I say, I'm going to share this with you because I think it's important to share. Right now is to cheer, cheer, cheer. If we have something sad, it will be to cheer, 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 and suffocate pain. So it's good always, and it makes us being together, and it makes us get through this and help those that are in the front lines, which are the ones that really are the big firefighters of this COVID. Yes, this is what I wanted to show vis-a-vis nursing homes, but I don't think it's only nursing homes. I think it could be also at home. If you live with a person that is 95, and I actually know a friend, and I just called yesterday, the husband of my friend Sarita Irmajin in BC, 95, and you know, he lived by himself, and I checked to see how he's doing, etc. And these are conversations that you need to have with people that you love, and certainly with patients. So I would like to show this video that was done by Michael Garron Hospital, which I think is fantastic.
Okay, just give me a minute if you can.
Oh, good. That's good.
Conversations about our wishes in the face of an incurable illness such as COVID-19 are very challenging. But being prepared for future events can also provide peace of mind to individuals and families amidst the uncertainty of these unsettling times. We wanted to share with you and your loved ones some information to help you explore, share, and document your goals of care in the face of the COVID-19 pandemic. At this time, there is no curative treatment for COVID-19, but we can offer supportive care. For those that develop severe symptoms, we can provide oxygen, medications, and intravenous or subcutaneous fluids. This is why, in long-term care homes across the city, we are expanding access to physician and nursing support so that testing and necessary care can be delivered without the need to be transferred to a hospital. It is our hope that with these increased healthcare supports and resources that you or your family member can be cared for in your long-term care home.
If you or your loved ones have worsening symptoms and require more oxygen than can be delivered by nasal prongs, then the next option would be intubation, which is placing a tube down into the lungs to help you breathe and to be placed on mechanical ventilation in an intensive care unit in the hospital. Emerging information on COVID-19 in older, frail adults and those with underlying health conditions, such as diabetes, high blood pressure, COPD, cancer, and dementia, suggests that these people are at an increased risk of serious illness and death. While the average death rate for COVID-19 is likely somewhere between 2 and 4%, the death rate in older patients, and especially those over 80, is much higher and likely closer to 15%. Once a patient with COVID-19 actually requires intubation and is placed on a ventilator, the mortality is over 80%. And in a recent study, as high as 97%.
Artificial life support is the treatment that we can provide in the intensive care unit. Unfortunately, as people get older, the likelihood of them surviving after receiving this treatment goes down significantly. While receiving life support, patients often experience extreme suffering and can lose much of their dignity.
Every medical intervention has pros and cons for people of all ages. These should be considered in light of what living well means to you. No matter where you are cared for, your healthcare team will work collaboratively to ensure that we do everything we can to meet your goals of care. Once you've had the opportunity to explore your wishes with your family, please ensure that your family member, family physician, or nursing team have your wishes clearly documented to guide your healthcare team. We hope that you stay safe and keep washing your hands.
Isn't it fantastic? Never ever they spoke about having or not having ventilators, right? They spoke about what people in that situation, right? Options are, and what this will mean and what this will mean, and the options, the result of this even, right? Like I thought it was masterfully done and with so much honesty. I just really loved it. It really, you know, I have been struggling so much with the issue of older people in nursing homes myself in terms of, you know, how to help, right? This really helps you switch on how to really help. So I was just very impressed with the work they did. Yeah. Okay, so are we done with questions? Are we good? Was this helpful?
Good. I think we're good.
Let's ask this. We have still 30 people. How many people think from 1 to 10, without us knowing? 1 is terrible, 10 was very helpful. 1, 2, 3, 4, 5, 6, 7.
You're
8.
getting lots of 10s here.
Okay, well then we go home. We are home. We even cannot go home. Listen, today I called Heather and I called her to the office. Here you go. Like, I can't switch the switch, but I'm home. Yes. Thank you guys and see you next week on Monday.
Okay, thank you, Doris. Good night, everyone.
Thank you, everyone. Good night.